we need our patients to trust us. We go to school to train in this profession because we want to help people. And helping somebody does imply that there is some trust they put in you. Yeah. And one of the things I don't want to use the word hate because it's a strong word, but going to places and thinking, oh, you can't trust your doctor. Why can't you trust your doctor? What have you heard?
Hello and welcome to GPs Talk Cancer, brought to you by Gateway C. I'm Dr Rebecca Leon and I'm joined by Dr Sarah Taylor. We're both practicing GPs and GP leads for Gateway C, and in this podcast we share our clinical experiences, reflections and practical insights into support earlier and more confident cancer diagnoses in primary care. Before we begin, a quick reminder, although anyone might find this podcast interesting, it is designed for primary care health professionals. All patient cases are based on real clinical experiences, but are fully anonymised with no identifiable information. Gateway C is a free early cancer diagnosis resource funded by the NHS and based at the Christie NHS Foundation Trust. So today we're going to be sitting down and chatting with Dr Sylvia Kama Kieghe. So Sylvia is a GP working in Sheffield at the local out of hours currently, but she's also a women's health content creator at Ask Away Health. Bit of a bio, because you're a very impressive lady. So Dr Sylvia is a UK-based NHS and private GP with a specialist interest in women's health and preventative medicine. She's the creator of the YouTube channel Ask Away Health with Dr Sylvia, where she uses simple evidence-based explanations to tackle common myths about hormones, contraception, menopause and other women's health issues. With over 90,000 subscribers and millions of views, she focuses on translating complex medical information into clear, compassionate education for women. So we're going to do things slightly differently today.
We are.
We're not going to be talking about early diagnosis. The title of today's podcast is Young Women, Contraception and Tackling Cancer Fears. So welcome, Sylvia.
Thank you so much for having me.
And welcome to rainy, stormy Manchester.
I know.
I'm hoping you're going to get back to Sheffield okay on the train later.
I should do. Sheffield was also very wet and rainy, so...
Yeah, the storm's running through. You okay, Sarah?
Yes, good, thanks.
Did you knit that jumper?
No, I didn't, but I have ordered a...
You were talking about knitting.
Yeah, I've ordered a Claudia jumper to knit.
What colour are you going for?
Ruby.
Did you watch The Traitors?
No.
Okay, so Claudia Winkleman had big knitted jumpers.
Oh.
Yeah, so
And our guest yesterday had one. So
her mum had knitted her 80-year-old mum, so Sarah's on a mission.
I love the idea of a ruby, very deep red.
Oh, be gorgeous.
Really good.
I won't because it'd be really thick and I'd be far too hot in here on it. But,
Good. Okay, so today's slightly different. So I want to ask, first of all, Sylvia, how did you get involved with content creation?
Very accidentally, I think is the best way to put it. So this is going back quite a few years. When I was a salaried doctor, I was working at a practice in Bolsover near Chesterfield. And my experience was having women come to ask me questions and always running out of time, as it happens. And so I think I was just moaning to a friend and they said, well, why don't you just do videos about what you're talking to patients about? I thought, me? Never. I'm shy. I can't. What? The whole world will look at me. So that was how it started. And I think the idea just stuck. And I did a few very, very cringy kind of videos. And I think it's just become like an addiction for me to carry on doing them. But more recently, so in the last maybe 5-6 years, it's become so important in terms of healthcare and public health and preventing all sorts of problems. I think we saw it very clearly on the back of COVID, but I'm sure it was there before, where there are all sorts of stories that are not correct, that appear plausible, and so they take away from our patients. Our patients are more online today than they were, say, 10 years ago. Everybody's got their mobile phone or whatever. And so if they can't get to their doctor ASAP, the very next thing is I'll Google this condition and maybe come up with something that's not right. And I think that for me, it's become more of a passion to see what can I do to contribute to helping to combat that. We're doing this in our surgeries when we get our patients in front of us. But online, where young people are, where the rest of us are, whether it's Facebook or Instagram or TikTok, you're seeing things being described or discussed by people who are not trained in medicine. They're not registered by regulators, so they're not being careful about what they say, being aware that this could get you into trouble. And they're just pushing it out, and misinformation does spread faster than
And I think, I always say this when I do a coil fit clinic every few weeks, and I always say to the patients, the people who've gone online tend to be the ones who have had a less positive experience.
Yes.
All those people who have had a very easy fit, which is the majority of the patients who are, like the form of contraception, have no side effects and are quite happy, are too busy living their lives to go online and comment on it.
Yeah.
Whereas the people where there's been an issue,
Yes.
whether they've had side effects or they've had a difficult fit or whatever, are the ones who've gone online. So what you get is a complete skewing of the information, and I think that's not helpful to people either.
Absolutely.
So the people that watch your videos,
Yes.
What kind of age bracket are we looking at?
So I've got all ranges, to be fair, mostly women, because my channel on YouTube tells you who your audience is or are. And so I've got women from all ages, and the majority of them are between the ages of 20 and 44, 45. But I've got people that are sort of less than 20, and I've got those that are sort of in their 50s and 60s as well. But the majority sort of fall into that age bracket.
UK based? Or
UK everywhere in the world.
Where's the furthest have you seen?
I mean, I got a letter from quite an engagement with this person from the Philippines.
Nice.
And from, well, France is not too far from here, is it?
Okay,
But, actually from quite far away, not from the US. It's
Okay.
international.
So what we were going to talk about was the things that people worry about.
Yes.
So the myths that and the thoughts that women have that contraception could be causing cancer.
Yes.
And I think that was where we wanted to come from today, not looking so much at the early diagnosis of cancer, but looking at what people think and how, and as you said, if we don't address those thoughts and their concerns, they're going to go somewhere else and they're probably going to get misinformation.
Yes.
So do you want to start talking to us about case one?
Yes, absolutely. So one of the things I do in terms of getting ideas for my videos is I get them from my patients many times. If somebody asks me a question, I respond. I think there might be somebody else who wants to know that information, but there's something else I do in this finding content is I go on forums like Reddit, Facebook, just where they're having conversations about this. So I picked up this conversation that somebody had shared her whole problem out there because people are confident and they're looking for information. So she put all this information, and this is a young woman, mid-20s, who had been using the combined pill for a few years, I think about 7 years. She'd used it for about 3-4 years, and she'd had problems with heavy bleeding, and then I think they switched her to continuous use, and she'd been fine until a few weeks before she set out this post, where the problem was she's having irregular bleeding. Initially, the bleeding was light, spotting, she didn't worry too much about it, and then it became heavier, almost like a period, and this was significant bleeding. And it wasn't just bleeding. She was also getting some cramps, and she was feeling embarrassed about having sex. So it was causing problems. Now, she did go to see a doctor, and the conversation went, I don't know how it went. The doctor talked about treating her with silver nitrate, but she wasn't convinced. She felt, there's something more to this. She went back home and was busy searching things like breakthrough bleeding on the pill and bleeding after sex on the pill, and then was getting all manner of, any type of bleeding when you're on the pill could be cancer. And if you've been on the pill for this amount of time, it's probably cancer. So there was this panic that set in. So she was sort of seeking advice from everybody else on the forum. This is not a medical forum, it's your average social forum. And wanted to know, what do you think about this silver thing? Are you sure they're not missing something? I've done my smears. It can't be. Could it still be cancer? So there were questions in there that I felt were significant, and so I sort of thought, if I were to handle this woman in practice, if any of us were to handle this woman, she would come to us. We've got 10 minutes to deal with this problem of irregular bleeding on the pill, continuous pill, a patient who's anxious, worried, petrified that she's got cancer. and wants to know what next, what can I do, how can I tell, what's the next thing I should do. So obviously, we're going to go through history. We're going to try and identify the pattern of the bleeding, the nature of the bleeding, associated symptoms, because she's got a genuine symptom that we have to look into. And then, any red flags, because she's talking about cancer, but we from our training know that there's some things that we could be looking for and should be looking for. Check, has she been taking her pill as she should be, really?
Compliance.
Exactly. What else? So, sort of do our standard history taking for this patient, and then, of course, examination. Because you want to have a look at what's going on down there. So you want to examine, cervix, do a speculum by manual examination, and then, think about investigation. So we will do the standard thing. But I felt there's so much more in terms of this patient's mindset.
Yeah.
And the fact that they've gone to a forum, they've been to a doctor who, for some reason, and a lot of the times I think it's a communication gap, because I know that in any profession you would have people that may not be, what you expect, but majority of doctors would sit down and give information. I've been a patient not too long ago, and I know the anxiety of being on that other side. And sometimes what the doctor says, you don't fully go away with it. So I think she might have been told things, but maybe she was too worried or she can't remember. And all she got away with was, I've still got this bleeding. They just want to do this silver treatment. But they're not talking about this might be cancer from everything I'm seeing. So it's about also unpacking that worry and addressing it. I feel being able to explain to her that, yes, we are going to be honest and say, you're taking this pill, this hormonal contraception. Yes, there's a slight increased risk of cervical cancer, breast cancer with this method. But what you hear on social media doesn't take into account that it's a relative risk of a very, very small absolute risk in the first place. So if, for example, talking to the patient, we'll use examples like maybe 10 women out of 100,000, for example, as a baseline risk. Yeah. Not taking the pill, just minding their own business, healthy women. 10 out of 100,000 could have cancer. And so when they then add the pill, you get a very small increase in that 10. It's not saying that you are at a 10% risk of cancer, but compared to the baseline risk. So it's providing that reassurance and in language the patient can understand.
So a couple of things I want to pick up from this.
Yes.
I think this case highlights, and Sarah and I are both nodding away because we can picture patients that we will have this. First of all, we were taught at base level at medical school about ICE, ideas, concerns and expectations. And this would be a fantastic time to really say to the patient, you've come in, complaining of these symptoms. What are you concerned about? Well, I've been Googling and they're showing this.
Exactly.
What do you hope from us? And then that's their expectation. Yes. And that takes 20 seconds. Okay. So that was the first question.
Yes.
Almost more. But as far as if we go back to basics as GPs, we've got a patient on the pill, young girl.
Yes.
Who has she had a smear?
She's had a smear.
Yeah.
She's had a smear. Her smear last smear was normal.
And smear was normal. And she's still having this irregular bleeding.
Yes.
And we've examined her, we've taken a history. We're not overly concerned.
Yes.
Okay. But if say she was somebody who wasn't that fearful, how do we as GPs safety net and also make sure that it isn't that tiny percent?
You think you have to get, I mean, there's two bits to this. There's a little way, so actually what we're normally talking about with these patients, these women who are on hormonal contraception, who get abnormal bleeding, we're normally talking about the fact that people just say, oh, it's GG pill and don't think about anything else. And I think that what you're saying, Sylvia, is absolutely gold standard practice where you examine, you take a full history, you examine the patient, you visualise the cervix, you take your STI swabs to make sure there's no infection. And then so by the end of that, I think we can be quite, she has got a reason for it. You can be quite convinced. And
how you manage do the other risk factors, don't we?
Yeah.
So the family history,
sexual history, you just
all of those things. So we have to, again, like a jigsaw puzzle, which we talk about everyone, that we have to put all this through. If we're quite happy that everything's okay, you spend the time actually saying, this is what we've done, this is what your relative risk is, this is quite common in the pill. But if this doesn't settle down, at what time frame would you say? A couple of months?
So I think it depends on what you do to try and treat it, doesn't it? So, if she, a lot of women, I would, in my experience, because I have a lot of young patients, at that stage would stop their pill.
Yeah.
And actually, if she stops the pill and it gets better, then that's okay, isn't it? I don't know if that's your experience.
That's absolutely, If it was someone that we didn't find anything at all, yes, stop the pill and maybe get her to come back after 3 to 4 weeks, because I would expect that, things will probably settle. So I might say to her, let me see you again in about 3 or 4 weeks' time. And then if you have any problems in the meantime, I think that's really important to emphasize, because you don't know what's going to happen. Come back to us, ring 111, the usual standard things that we say. Somebody like this, who somebody's already told her that there was silver nitrate. Now, my mind is thinking an erosion, for example, cervical ectropion could be the cause of this. And then, can we treat this or refer for treatment? And they might be expecting something. And I would add something else, because I don't know if it's just me personally, but I feel opposite to what you're suggesting. If there's somebody really, really anxious and you've said everything, you found nothing, you've done everything, but the anxiety is so overwhelming, is this somebody that you might consider getting a second opinion? Because we do have some patients like that.
Of course.
You've said everything.
Or advice and guidance as well.
Exactly. So they know that we're not, just
on our own saying it.
Yeah.
And we sometimes ask, I've sometimes asked one of my colleagues in general practice, either come and have a look or a second opinion,
yes, absolutely,
because of their anxieties. I suppose what we're trying to do with this woman is, first of all, work out, does she have any risk of cervical cancer if we're seeing her? And then once you're reassured, working out how you reassure her, bearing in mind that everybody on Isla has told her that she's got cervical cancer. So I think it's probably sort of saying to her, look, I've considered it, and we've looked at absolutely everything that could contribute to your risk of cervical cancer. I think it's extremely unlikely that's what's going on. And what we need to do now is try this and see what happens. And if it doesn't improve, but I think it's almost the flip side of how we would what we're normally talking about, isn't it? It's just saying, maybe giving her all the bits of the jigsaw that we've got, saying, well, you're a non-smoker, you've got no family history,
they
had your HPV vaccine, all of these things. We can, going through all of those, saying these things are all very reassuring, and that is what. But actually, you're right. If you don't ever find out that that's what she's really worried about, rather than that's what she's read, you're only going to do half of the consultation.
She would just go away and say, well, I saw the GP and they did nothing.
But also,
as a standard.
So again, it's the rapport you build, the trust. So it's, if she kind of believes you, if you go through no risk factors, no family history, you've had all the preventative with the smears and the HPV vaccine, we're going to stop the pill, we're going to review you. She should come away thinking, actually, I've been listened to here.
Yes, that's one
the main
thing.
thing.
That empathy and the fact that you've listened. And I wouldn't shy away from, addressing those things that she's heard. I think we should, because I think we sometimes hear them, and some patients come to you with clippings. I saw this online, doctor. What do you think? And in our heads we're thinking, because
the Daily Mail.
I know. And you're thinking, but you have to address it in such a way that you're respecting the patient, but then you're saying, well, this is not correct because of this one. Just like I said about framing. And I think part of doing this work has helped me realize more about how we could overturn what's been said online when they don't have time to really go into the difference between relative risk and absolute risk and say, look at the nitty-gritty. That's not really what this means.
No.
They don't do that because it's not sexy. It's not, it's not fun.
And I think that's that reassuring is something we talk about again with kids who've got a temperature. Parents bring them in, they're worried they've got meningitis. They're always worried they've got meningitis. And we can go and we would always go through and say, well, actually their temperature's okay, and they've had, Cocoa Pops for breakfast, and they've come in and they're smiling, and I've examined them and they've got no rash, and you'd say, I'm not worried about this. And most parents do feel reassured. But I think we probably don't put the same effort into some of our other patients to actually reassure, because it's not quite so obvious what they're worried about. Whereas you're right, I suspect I've had patients over the years who've come in with abnormal bleeding with the pill, and I've been quite confident, but I've not necessarily conveyed
because when we are training, Sarah, this wasn't, and this is something that we're dealing with as we're in practice.
True. Yes.
How much of this online thing where we talk. We weren't. But we have to deal with it because people are more online now than
and there's a lot
10, 15 years ago.
Particularly, you have to look at the cohort of patients.
Yes.
You work in a very student population. So you'll be dealing with this a lot.
Lots.
You will. And for me, my patients don't know what TikTok is.
Yes, maybe I should move.
Well, there are lots of people on YouTube. I mean, we had a meeting, the health community had a meeting with YouTube, Google, was it last year? Anyway, they were talking about how, I think it was 2021, they had 5 billion views of health videos. Billion. So it's a lot that people are searching. So when the patient types in, bleeding, or breakthrough bleeding on the pill, that's a search.
Really?
That's something she's looking for, that information.
Yeah. And you can find that kind of thing on a social media.
Of course, it's on YouTube. And one of the things that, the reason I like YouTube, because, you think, what they did is they created something called a health shelf in liaison with NHS Digital and the Academy of Medical Royal Colleges in this country, to put in criteria for people like me or organizations that share health information, looking at the criteria that we use, making sure that we're standardized.
That's really
And
good.
so if anybody types in breakthrough bleeding on the pill, blah, 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 on YouTube, it first of all pulls up authoritative health information, which is one way. TikTok and some of the others haven't got there yet.
Yeah, that's really interesting.
That's something that
health shelf. I like
health.
It's also useful just to know if you're directing patients to look for stuff. I send links to things by text, but actually, I would never send a link to TikTok or Instagram. But YouTube, though, for but it's useful just to say. It's useful to be able to say, if you're going to go and look at this, I would suggest you start on YouTube, because that's got properly sort of.
NHS is on there, and they've got. There's also something called the PIF tick. Sorry, this is just something that's so dear to my heart. But the PIF tick is an organisation here in the UK that gives accreditation to health educators or health information creators after they've assessed your work. They've got 10 pillars or so that you've got to make sure that your work is being produced in a systematic way. It's recognized, it's being inclusive, so you're using images that people, language that people can understand, and then they give you an accreditation. And so we're being asked to direct people to those health content because people can use them.
And that probably also applies to people who've had a diagnosis of cancer, because when we were talking about you, me and the Big C yesterday, weren't we? And we were saying, I remember listening to one of their episodes, and they were saying, the 3 presenters who had cancer were saying, I am so fed up with people sending me information about diets. If I eat blueberries or goji berries or something, or turmeric, it's going to cure my cancer. And actually, but it'd be really useful to be able to send patients who've got a diagnosis of cancer to reputable, apart from the charities, but actually to reputable other information because people actually want to do things themselves.
They do.
And
they
actually,
do.
So when you're talking about someone like diet, you're right. The main one I remember was apricot kernels. That was the big one. But actually, if they know that certain food groups will help with fatigue, and we're not going to say it's going to shrink your tumour, but it's going to actually make you start to feel better, sleep better, all the other things.
Or suits people with a chemo palate.
The taste disturbance.
So it'd be useful to be. So I think that's a really useful information to have, isn't it?
Absolutely.
So case 2, tell us a little bit about that, Sylvia.
So case 2 is an interesting one. So this is someone that, because I did a video, I think it was something on depot progesterone. I don't know, I just found myself doing videos on depot, and I think they'd watched it.
Just sit at night when you're a bit bored, Sylvia, and they go, I'll just do a video on this today.
There are different ways. I remember times when I would just hear something, that sounds like an idea for a good video. And then what you're encouraged to do is, go and check and make sure that this is what people are looking for. So there are random ways that these ideas...
Okay, sorry, I interrupted.
No, you're fine. I could go and think, actually something that Rebecca said, that could be an idea for a video. So you might feature in my video.
Fine. So I think it's about also being reactive as well.
Yes.
Things, if there's something big in the news, we know that they're going to come, and the fit test yesterday. So that people might be asking. They've reduced the
Screening threshold.
Threshold
Yes.
from 120 to 80.
Ah,
So
okay.
therefore, there might be
So England is now
Yeah.
in line with Wales and Scotland, which it wasn't.
They're also.
And Sarah loves everything about fit.
Oh,
Continue, Sylvia. Okay.
So she was just responding, and
Yeah.
sometimes people watch a little bit of the video and they may not watch everything, and just So their problem was they were having trouble with heavy periods, not massively, but they just heard that the depot shot is a low maintenance, every 3 months, so you don't have to think about taking the pill, and it will stop the bleeding because, of course, we know in most women amenorrhea will happen. So she was expecting life to be very easy, but I think within a couple of weeks after she started the method, she started getting these really bad headaches, which she termed migraine. As you would, she spoke to a friend and they said, I've heard that this depot could cause cancer, brain cancer. And the patient herself really wasn't initially worried, but then she heard this from somebody and then she went to type depot shot and cancer. And then a whole raft of all sorts of things came up about meningiomas and so on. And if you're on the depot shot, you could be at risk of cancer and all sorts of things. So that's what, that was the main concern. And I just sort of sat and thought about how we will deal with this person when they come to us. And my not just because, you want to review the symptoms, but you also want to address the information that she's picked up and that's gripped her, that's making her respond. Because what she would say or what she was thinking was, I don't want to have this hormone anymore. I want it out of my system now. I want to go for something natural.
Oh dear.
Okay. So, if she were sat in front of or seated in front of us, we would, first of all, like the first case, you'd have to review these headaches and be sure in your head what is going on with these headaches. She said migraines. Okay, they definitely are definition of migraines. We'll look for red flags because God forbid that it is this one case that comes in and there's something going on.
Absolutely, yes.
So you do all the history and you examine, do a neurological exam.
Getting it out of
I know.
the body.
Yes, exactly. Check her blood pressure and then all those things to sort of reassure us, where are we with this? And then if we're happy that it's not, I feel the other thing is to counteract this idea that the depot shot causes meningiomas. And that is the conversation that sometimes we don't have that conversation. We may do all the tests and everything, which is fine. But like I said earlier, because we weren't exactly trained in this thing of social media and the impact it could have on people. So again, it's about framing, reframing, and emphasizing that, these things you see on social media, these percentages, they don't take into account that there's a very, very slight chance. In fact, there is no evidence that there is a direct cause. This is sort of an association, and they're still looking at more studies. But there's a very slight chance. And for this person who is in her 30s, we know meningiomas are more likely to happen in older people anyway. So even her risk is low. And that will be part of what I would say to reassure and then overturn what she's hearing or what she's read in her social media scrolling. That it's not, don't get carried away by the numbers that they're telling you there. Here, we're looking at what is the exact risk in terms of the evidence, and it's not often described that way in social media. And then we would address, hopefully, having convinced her that, what you're hearing on social media is not the correct. Here we're talking about evidence. We have national guidelines. We have research that's been done. These are people who have studied these things. And then we have to look at what she's demanding. She says, I want this out of my system. Now, the depot shot is not something that you can just get out of your system.
No.
So then we have to explain to her that the way this medicine works is a big amount, how do you say bolus? I don't want to use jargon. A big amount that goes into your body with the injection, either in your muscle or in the fat, whichever method. And it slowly is released into your blood. So it's not something that you can flush because, the funny thing about these social media algorithms, once you type something and you search and watch something, guess what happens to you the next day?
It takes you down.
Yes, you go down a rabbit hole. So you're going to get videos about supplements that will cure meningiomas or teas or steaming treatments.
And I'll be buying them all.
Oh, come on.
I was just saying I'm very gullible.
It's amazing, and so somebody wants to, if they're saying, oh, what if I try this tea to flush out my, the way it's slimming teas and all sorts of things. And because it's natural, and this is the opportunity to say that, and, I've said it to people, just because it's natural doesn't make it safe.
And it'd be interesting to actually say to people, what do they mean by natural?
That's a good point, actually.
When I think of the word natural, so if you think about a natural contraception, I would think basically taking nothing and just relying on your natural cycle.
Fertile days,
and your fertile days. And so almost doing the opposite of trying to get pregnant.
Yeah.
So you have sex on the days when it's likely to be safe. That's a natural contraception.
There's some people who will swear by that, actually, Rebecca.
But I think natural contraception to other people is taking blueberries with a bit of
they used to
they
used to do all sorts of things. They used to take all sorts of drinks back, ages ago, and would swear that it would work. So it's you're trying to.
So I think what we've done for years with patients is reassure ourselves that there's nothing serious going on, which we do. You do. That's what you do.
You do well.
Chest pain. You have your tick list, and you sort of go, right, actually, I'm not worried about this. But what you're saying is that we need to start, making more effort to reassure patients and to understand what they need reassuring about.
And
it's and it might be something completely different from what we're thinking about because they're not medically trained and they might have picked up on something that is just we won't have thought about.
It's quite striking.
Yeah.
It's like what Rebecca said about ICE, which is what we do.
Yeah.
They say they're worried about cancer. This is an aside. I came across, again, was it Reddit? You think I live on Reddit? I promise you. Well, I came across this woman. She says, I'm just posting this video I got from TikTok because it's got so many views. And there was this person who's not a doctor talking about fibroids, and he went through, he was very dramatic. I never knew this about fibroids. This is such a terrible condition. How do women go through this? Did you know that even doctors call fibroids benign? How can they say fibroids are benign? Because it causes so many problems. It does. I was like, wait. Yes, they are benign. When we say they're benign, we're not saying that they don't cause problems. We mean they're not
benign
cancer.
Versus malignant, exactly, to explain.
But then, do you know the worst bit of this video was the comments, or this post on Reddit where comments from people saying, he's explained it so well. My doctor never said anything. And that pinched me when, they said my doctor never.
And you've done one on fibroids. That's the one I want.
I've done.
Yes.
But it's just sort of, this is what our patients have in the back of their head. They may not say this to us. But one of the gains of, having health content creators like us on social media is being able to try and push back. It's a bit of a slog because, the more fantastic and scandalous the news sounds, the more it flies. But me trying to explain about fibroids and, may not be unless I'm sort of doing something really extra with it.
But the comments is interesting because I look at the comments, whether it's a news article, but I think you're absolutely right with, so I'm on a few Facebook forums and I quite like them because some of them are GP run. Some of them have had to leave for various other reasons, and some of them are just talking about busy life with children and being a GP. So it's a combination.
Yeah.
But actually, what's really helpful is the comments because it can, and a lot of these are GPs and GPs are commenting, so that's helpful. But if I'm on any ones that are the general public, it's this. They're fascinating about what they're believing and what they're pushing back on, and the word that I've taken from both of these cases is validation.
Yes,
which I think is a really lovely word because I think it's the word that explains what we need to do in practice. We need to understand what they've come in with an agenda.
Yes,
the patients. They've come in with symptoms, but they've also come in with an agenda. And unless we tease it out of them, they may come away not feeling fulfilled.
Yeah, and you're right. You point that you actually have to just go through this and just make sure this isn't the one patient who's got really worrying headaches.
Which we do anyway.
Which probably is the easy part that we would do.
We're trained already.
It's the bit about going back and saying.
But the thing about it is also as well is about empowering our patients, which is what it's what we do. Yeah. Somebody comes in with a problem, you feel how do I get them when they go out of this room? They feel in control, back in control, and not weighed down by this problem. And a lot of it is about trusted information.
Trusted information is something that I do. I mean, I send out NHS leaflets, but actually using the trust, knowing that there is that stuff on YouTube that you can use is really useful.
But I think also I use Rock My Menopause.
Yes.
And the reason why I also like that is I think it's a bit cooler than some of the NHS stuff. No offence to NHS, you pay the bills. But if you're sending it to people who they can relate to, then it's more likely for the information.
Spot on. You've hit the nail on the head. And the NHS does work with,
with certain people.
They're
not very exciting leaflets, are they?
I know. But their videos aren't too bad.
Videos are better.
They're not too bad. And I've done something recently with them. And again, you've hit the nail on the head. It's about representation. See somebody like me.
Yes.
You actually,
absolutely.
or just, my scrubs on my coat, and they sort of, it's not just a blank.
Yeah.
But they can relate, they're looking into my eyes and that believability. So I think that's a lot to do with it.
Yeah.
And just finishing up with this person in terms of her natural treatment, let's give her the options. And, a fertility awareness method and its risks of pregnancy. The College of Sexual and Reproductive Health have this lovely website, Contraception Choices. I love the graphics. I use that because you can just sort of click on the method and turn it around to show the patient. And
quite fun.
Really, and you can see it. You can see it, and you compare it to maybe condoms, or you compare it to the coil, and you can see it. Do you really want to play this kind of game at this time in terms of unwanted pregnancy? And put the decision there for, let's think about it. And it's sort of going there. The only challenge I have with this is we've got 10 minutes to do this. And so there's one practice. I haven't done that, but I respect this practice. I can't remember their name. I think they're in Holborn or something in London, where they've got a studio in the practice and they do health videos. And so their premise is, in 10 minutes, I can give this information to one patient. If I did a video and put on YouTube, I can give this information to who knows how.
There's more and more studios doing that. There's one in Wilmslow that does this. And it is.
So maybe that's the one that I'm thinking about.
Yeah, and they put it onto their
it's a good idea.
Their website. So it's more things like using Factor 50. All that kind of thing. If you're not just educating one person, you can educate 100.
Yeah, absolutely.
Okay.
So I think I think it's a new way of thinking about things for us, isn't it? And I think that sort of whole reassuring, being as rigorous and reassuring as you are in your assessment, and appropriate is quite because I've not really thought about quite. I'm aware how much information, particularly from the coil clinic, how much misinformation is out there, but I think I'm probably massively underestimating how much people have.
I think there's one thing that encourages me. So I don't know if we've still got time, but there's I can't remember his name, Dr. McDonald. He's a GP as well, and he shared on LinkedIn. He said when he first started doing videos, he's much older than me in this business, and when he first started doing videos, nobody encouraged him. I think maybe one of his mentors or trainers said, "Why are you wasting your time on this?" So anyway, he shared a comment from one of his videos from a patient who said, "I want to thank you, Dr. McDonald, for this video." Was it something about appendicitis? Because as a GP, he does all sorts of GP things. And I think his video was just about, this stomach pain in a child. Anyway, the long story short was, this person who'd watched his video said because they'd watched that video, when their child had they didn't disregard it, they took him to hospital and it was appendicitis. There's sometimes, people may not come back and tell you, but sometimes it does make a difference.
I'm sure that it makes a massive difference.
It does.
Yeah, because I think you can give people information. And also the other benefit of people having good information before they come in to see us is that it does help them articulate what they are concerned about.
Exactly. That's another one.
So that that we then understand what their concerns are. And if it's something serious, then it is easier to identify it sometimes.
Absolutely. Yeah.
Okay, I want to talk about some key takeaways from GPs. We can do one each.
We can.
So I'll start with number one because I feel like doing number one. Approach to bleeding on hormonal contraception. So following the case, I think it's important we have a practical structure like we always do. History, examination, any primary care investigations. And we want to assess unscheduled or post-coital bleeding, ruling anything out serious, including cancer, and more than ever explaining to young women why most bleeding is not concerning, but we don't want to minimise their fears.
Yes, absolutely.
Sarah?
Okay, so I'll just do something on the second case. So just addressing the fears that people have about hormones, brain tumour and cancer with evidence and empathy. And I think that really involves what you were saying, Rebecca, about getting their ideas, concerns and expectations at the start of the consultation, taking a thorough history and assessment, and then being quite rigorous in your explanation.
And number 3?
Number 3, yes, navigating the natural versus hormonal conversation. So looking at strategies for discussing natural methods and detox ideas, being confident to explain where the evidence is strong or weak, because patients will come in front of you and say, what do you think about this? And you haven't got a clue. But it's important to say there is no evidence. You know, we haven't got any evidence for this. It's not my fault, or there's still research being done on this. And we can say that. And really important, maintaining trust when patients request non-evidence-based approaches, because we need our patients to trust us. We need we go to school to train in this profession because we want to help people. And yes, we want to have a career and all that, but you want to help people, and helping somebody does imply that there is some trust they put in you. And one of the things I don't want to use the word hate because it's a strong word, but going to places and thinking, you can't trust your doctor. Why can't you trust your doctor?
Yeah.
What have you heard? Anyway, that's I think is really important in that conversation.
Fab. And the final thing in the podcast is we have a word of the podcast. So something that you may have picked up from one of us, something from what you've been explaining. Is there anything that you've learnt on this podcast? So a word.
Can I go first then?
Yeah.
Health shelf.
Health shelf. So you've learned that now YouTube have
validated medical information that you can direct people to.
Okay.
You'll have even more subscribers.
Health shelf.
Yeah.
Sylvia.
Oh my goodness, I've heard so much. I don't know why ice comes to my head because I know ice.
Yeah, but ice is good to revise.
It's good. I really love that because, we're trained to do this and sometimes patients are afraid to bring it up. So if we push a little bit more, it could actually help us and you could just focus your conversation and not sort of go in different directions. And the patient will feel that I've been listened to. It doesn't have to be that you leave with a prescription. So ice is back on my radar.
Ice is back on. Okay. And I'm going validation.
Yeah.
Just almost following on from the ice, actually saying to the patient, that's okay to feel like that.
Yeah.
And thank you for being honest with me. And then we take it from there.
Yeah. Or framing reassurance.
Yeah.
Like framing reassurance.
Framing reassurance.
Yeah, too. I've had that. 3 words I'm having freely today.
So thank you for listening to GP's Talk Cancer from Gateway C. You can access our CPD accredited modules anytime via our website, and all reference studies and guidelines for this episode are linked in the show notes. If you'd like to submit a question for any of our to-be recorded episodes, please make sure you sign up to our Gateway C mailing list. The link is in the show notes and you'll receive a survey link. Alternatively, please email your questions or thoughts to the chrissy.gatewayc@nhs.net. A big thank you to our guest Sylvia and to our producers from Gateway C and Listening Dog Media. If you haven't already, please follow the podcast so new episodes drop straight into your feed. And if you think a colleague would find this episode helpful, we'd really appreciate you sharing it. It helps us reach more primary care health professionals and making better diagnoses. Thank you for joining us, and we'll be back again soon.